one. Did you get to watch any of the other?
I was going to, and I thought I'd better not because it might put me off.
We're live team, I think.
Okay.
Morning, everybody. Thanks for joining us. My name's Rob Sapsford. I'm a GP Fellow at the Training Hub, and I'm joined by my colleagues, Dr. Alison Hibbert and Jay Over. Alison's the clinical lead for dementia for NHS Kernow, and Jay is an ex-ITU nurse and a resus officer for Cornwall Foundation Trust. This is the fourth in a 5-part series of webinars focusing on dementia, and the focus on this webinar is on end-of-life care and how we may be better able to manage our patients in primary care as they enter that phase of their life. So without further ado, I'll hand over to my colleagues. Please do engage with us throughout the webinar using the chat function at the bottom. I'll disappear off screen now and let my colleagues carry on, and I'll field your questions to our panelists throughout. If you could send them in to us, that would be great. Okay, hope you have it's enjoyable, and see best of luck, everyone.
Okay. Thank you, Rob. Thanks for that. Now, let's get the slides up. Yes, so it's quite a big topic, actually, thinking about dying well with dementia and focusing on the sort of end stages of dementia. First thing, what we'll be covering is that we need to recognise that there is an end stage to dementia. I'm just going to also show some sources of help. And then a major part really is thinking ahead, advanced care planning and treatment escalation planning, which Jay's going to cover for us. So, is that lovely? There we go. So first of all, what we should remember is that dementia is a long-term progressive condition. It is now our leading underlying cause of death in the UK. It has overtaken from ischemic heart disease and from cancer, so is now pretty important. It is a progressive condition, and that the trajectory of illness can often be slightly sort of uncertain and up and down. Unlike a cancer diagnosis, we know that the trajectory is more sort of slow downwards. With a long-term condition like dementia, the trajectory can be slightly up and down, but overall the direction is downwards. So what we do have to recognise is that early on in a dementia diagnosis, or even noticing the benefits of a diagnosis, is so that actually a patient can be included in their care planning and express their wishes. Dementia is a condition whereby people can lose capacity later on in the illness, and so really important to make the diagnosis early and to catch somebody's wishes rather than relying on sort of guesswork later on. It's also important to kind of plan ahead so that we can make sure that we get it right for the person, get the right care, and that's really key to having a good death or dying well, really, with dementia. So I have to say, have the conversation, start these conversations early, and I would like to give credit to Cornwall Hospice Care, who have helped me put together some of the key points for today. And I think the key point really from the consultants there was have the conversation. These conversations are difficult, they aren't easy, but done sensitively and given time, they can make a real difference to patients and their carers. So we should really recognise what is the end stage of dementia. Dementia is a progressive condition, and as I said, the trajectory can be slightly uncertain, but we do know that death will be inevitable in the end. Often it can be with other sort of comorbid conditions, and if there are other conditions that can sort of hasten the deterioration. So in the later stages of dementia, the memory loss can be really quite significant, that the person at that point may well not even recognise or remember their loved ones or people really close to them. The concentration may be really affected. Mobility can be affected. They may at that stage be unable to kind of walk or sit up unaided or even become bedbound. Communication can be real communication difficulties, especially with speech. They may not be able to make sentences or even sort of use one or two kind of words, or they won't be able to make sort of sentences. And actually understanding can be affected, and this is really where it's difficult, because people need to be able to express a need, and so there may be behaviours that challenged, or gestures which are trying to communicate an unmet need because they have communication difficulties. There's often a sort of loss of appetite, a loss of eating, difficulty kind of chewing or swallowing food, and a sort of reduced food intake can often be particularly distressing to family, to relatives, because often that's seen as something sort of vital. But later in life, when somebody's near a terminal phase, often they won't need the same amount of calories, their body's sort of shutting down and their appetite will go, and we have to be careful about sort of force feeding people at this stage. Certainly latent dementia and incontinence can be an issue. There's increase in general frailty, maybe increase in falls. We can see in the last year that people have increasing sort of hospital admissions. There's an increased risk of infection alongside the frailty. Pneumonia can be a common sort of event, and certainly recurrent pneumonia can be a poor prognostic sign. There's often sort of increasing fatigue. And as I said, there's often comorbid conditions alongside. But it can be difficult to recognise the sort of end stages, and it's always worth kind of reviewing whether somebody's got a reversible cause. If they're increasingly agitated, are they trying to express pain? Is it sort of bladder, bowel symptoms? But overall, if you put all the tools to sort of all the signals together, you'll be able to kind of recognise the later stages. So in terms of palliative care for dementia, and palliative care is a wide and huge topic, but just some key points really, that what we do know is that we need parity for palliative care with cancer for dementia. We need parity with cancer. There is equal access to specialist palliative care services for people with dementia. And that Cornwall Hospice has a specialist palliative care advice line, and that they are more than happy to be contacted regarding somebody dying with dementia, especially if there's sort of problems with pain control or agitation, but certainly use their specialist palliative care line. On the website, we'll add the telephone number. There are tools to help us recognise the end stages and the sort of terminal phase. Two used locally are Gold Standards Framework, and there's also the SPICT tool, Supportive Palliative Care Tool and Indicators. So really, what should we be doing towards the end of somebody's life, certainly in the last year? Really key to sort of review somebody's medication. We need to reduce the tablet burden. Often people will have been prescribed medications earlier in their life to kind of perhaps treat long-term conditions such as diabetic medications, blood pressure medications, but really towards the very terminal phase, certainly the last days, these may not be kind of required. Certainly if somebody's not eating and drinking well, their blood pressure can be a lot lower. And if we lower the blood pressure too much, then that will increase the risks of falls. Certainly somebody in their last year of life, we're not so worried about their cholesterol level, and a statin may be more harm than good. As for somebody in their last sort of months of life, really the sort of bone protection treatment may be of very limited benefit, but is giving the burden of having to swallow extra tablets and may put them off actual sort of food. So really kind of review the medication, reduce tablet burden, focus on what they actually sort of need for symptom control, focus on quality of life rather than quantity. Can't emphasise enough really that carer supports and support for loved ones is key really. Explaining what's happening, explaining what may happen nearer the sort of final days and hours. Really important to make sure they feel supported. So symptom control can be the same for a person with dementia. A sort of generic palliative care, we focus kind of mainly on the key symptoms: pain, agitation, nausea and vomiting, and right at the late stage, often there's medication prescribed for secretions. But I would like to emphasise that pain is often undertreated for people living with dementia. This is particularly because of the difficulties with expressing themselves. And so it's really important, there are some non-verbal scales for assessing pain, to use sort of non-verbal cues such as gestures, facial expressions, grimacing. Really key to get pain control adequate, because the undertreated pain can often be a cause of sort of agitation. So with other end-of-life conditions, we use anticipatory prescribing, writing up for medications that the person may need before they're needed so that they're available. And actually that's no different for somebody with terminal dementia right at the last stages. Pre-planning, having the conversations and having any medication needed kind of ready is important. And also to review forward care planning, really. We need to think about reducing inappropriate interventions at the terminal stages of dementia. Some of our treatments can be more harm than good. Repeated courses of intravenous antibiotics, feeding tubes, phlebotomy, and CPR, which Jay will talk about. Certainly, so repeated kind of infections can be a late sign of dementia. What we know with regarding feeding tubes is that they do not reduce the risk of aspiration, and overall they don't increase kind of prognosis. Again, thinking about phlebotomy, are we doing more harm than good by repeatedly stabbing somebody? Do we actually need those blood tests? It's all a case of weighing up pros and cons. Now, it may be that just to assess to see if somebody has got infection or problem with their electrolytes, then it may be justified, but just have a careful think about whether you're doing more harm than good. Will the results of the investigations change the management? That's sort of key to think about. Also, with acute escalation, what we do know is that people with advanced dementia towards the end stages actually do very poorly with an acute hospital admission. The environment's very disorientating, it's very distressing, and will they be offering a treatment that will be of benefit? Could that treatment have been provided in the community? Should we be focusing on palliative care in the community? And sometimes we see that people are escalated just for symptom control. Well, actually, if we'd done prior planning and had the discussions, we may have had anticipatory prescribing that could have been prevented. So there are lots of sources of help out there, really. And as I said, the generic sources for help apply, really. Palliative care for somebody with dementia should be equal to palliative care for somebody with cancer or heart disease. Marie Curie website has a lot of really useful information. Can't emphasise enough how brilliant the Dying Matters website is in terms of advanced care planning. Really good source of information to signpost patients and families to, and also information for professionals. The Alzheimer's Society has some comprehensive advice on all stages of dementia, but also particularly in the late stages, and also have helplines, which would be a good source to signpost carers to. As well for Dementia UK, and they have the Admiral nurses, but their website also has some really useful information, as does the Cornwall Hospice website. And Cornwall Hospice has a specialist 24-hour palliative care line, which is open for us to use in Cornwall, and I can't emphasise enough how good that is and how helpful they are. I've often used that myself, actually, with some tricky symptom control. But really, the thing that's key is advanced care planning, thinking ahead, having the conversations. The benefits of an early diagnosis are that we can find out what somebody's wishes are before they lose the ability to tell us. So there can be advanced statements. Somebody could write down what matters most to them. What do they want? What treatments do they want? Then there's a more legally binding, a formal advanced decision to refuse treatment. That's more about what they don't want, and that could include resuscitation, feeding tubes. So that's more legally binding document. There's a lasting power of attorney for health and welfare, and certainly somebody could appoint an attorney. I won't talk much about that because that's going to be covered in webinar 5 when we're covering some of the legal aspects, and also we'll be talking about the Mental Capacity Act in the next webinar. But perhaps also key is our treatment escalation planning, which, without further ado, I shall hand over to Jay to cover for us. What is TEP? What is treatment escalation planning?
Thank you, Alison. Thank you. I just thought I'd put it into a little bit of context about where I'm coming from and what drives my passion to get this right, and why I've made that statement that a TEP is a step in the right direction. As Rob said, I'm a resuscitation officer now with Cornwall Partnerships, but prior to that I was a resuscitation officer based at Treliske, and for 18 years I carried the cardiac arrest bleep. And as Alison said, it's about we've got one chance to get that patient's death right. And in 18 years, the number of resuscitation attempts that I was party to, where we absolutely did not get that patient's death right. It is absolutely vital that we start, as a society, start talking about death and dying in the context of it being normal, to normalise it and understand a bit more about what CPR is and what treatments are and aren't. So I've put a little bit of background here about where it all began and how we seem to have got into sometimes, I think, a little bit of a pickle, certainly over the CPR decisions regarding advanced care planning. And certainly 32 years ago when I started as a student nurse, we had NFR, not for twos, DNAR, DNR written in the patient's notes. And it was our authority not to perform CPR in the event of a cardiac arrest. Now, these decisions were based on the fact that it was never meant to be around somebody's death. CPR is never supposed to be a treatment that we would consider to halt somebody's death and dying. But we needed to have a position, and the default position was we would perform CPR on anybody in whom didn't have a DNR decision. But it was really in the year 2000 that the story of Jill Baker hit the headlines, and she was a 67-year-old lady who, although had terminal cancer, was admitted to hospital for more palliative treatment, and discovered on her discharge that she had a do not resuscitate decision in her notes. And it hit the headlines publicly, with many tabloids saying that the NHS was ageist. It wasn't discussed with her, and that doctors were making decisions around patients' CPR status. So the NHS directive wrote to all trusts in 2000, it was 2028, to say you've got to put your house in order. Now, interestingly, in 1995, I've still got the one A4 page, do not resuscitate policy that was at Treliske at that time. And these bullet points are exactly what we have in our policy today, the underlying principles of good communication, talking to patients, talking to their relatives, good and clear documentation. But we still just didn't seem to get that right. And I think it was an avoidance, not because we thought that we were knowing best. It was about trying not to have distressing conversations with patients. And it was 2014, the significant legal case of Janet Tracy, that set the precedent that if a patient had capacity, then we should be discussing. The problem with that case was about the terminology that the courts were using. And they were saying that you must consult patients. And I think some clinicians felt that was must ask patients what they want. So there was also at the time some significant research from the National Institute of Health Research with Heart of England and Warwick that looked at the perceptions of patients and clinicians at that time around do not resuscitate decisions. And it was clear. Patients felt a do not resuscitate decision meant it was a death sentence, that they wouldn't get any treatment, that they were dying in the context, I said, just straightforward, do not resuscitate. And even there was a perception amongst clinicians, they found in their research, about patients perhaps not getting as many reviews as other patients. And what they found, and is in the joint statement I'm going to be talking about, is that a single point of a DNAR form was not the way to go. And that clinicians needed to have this broader conversation and put into the context with that an escalation plan. So it is clear for some patients there will be escalation despite a do not resuscitate decision. But for some patients there wouldn't be. So there will be comforting treatment, but not escalation treatment. So it put it in that broader context of what actually CPR meant. So I'm going to go through the law. The difficulty with law is when it's applied to ethics, there are grey areas, hence the slide. So law might feel in some certain context very black, very white. But when you throw ethics in, medicine is about what you can and can't do, but ethics is about what you should and shouldn't do. And that's often what becomes most complex. And it is this, are we going to distress, are we going to harm, about having these conversations with patients. So I'll start off actually with some terminologies I thought I'd just explain. And I'm coining a phrase about menu decisions, so on menu and off menu. Okay. And in fact, it actually came from Andrew Andrews, MBE, who presented at a conference in Treliske in 2017. And Andrew Andrews is a now retired but very prominent healthcare barrister who actually participated in the Mental Capacity Act development, who said it is about menu options. Treatments are either on the menu or they are off the menu. And that will guide us in how we have those conversations if we know what point we're coming to talk to patients. And it's all about benefit versus burdens. It's a balance. Most treatments, whilst there are benefits, will also have burdens. So you think about operations, there's relative risks, chemotherapy risks, drugs, side effects and risks. And the best treatment is obviously where the benefits outstack any burdens. And you can absolutely say that treatment will be on the menu for the patient should they wish to accept it. But as I said, most treatments have some burdens, so that still can be on the menu. But once again, it is vital and critical that as part of this legal process, we discuss with patients about whether they want to accept those burdens. But here, the treatments, burden versus benefit, it on the menu. It's when we get to the treatment decisions where the burdens far outweigh any potential benefits, or there is no purpose to provide that for that treatment. So, for example, there is no purpose in trying to provide an attempt at CPR if that patient is dying. So here we say off menu. Some people will say futility, clinical futility in its purest forms. A lot of ethicists don't like the use of the word futility. But clearly, where the burdens far outweigh benefits, it is off the menu.
We wouldn't offer it.
So this is what we're going to come and talk about now. So we're going to be talking about the decisions, and absolutely, we wouldn't be offering it, but it's about how we do have that discussion. Yeah. So absolutely. So we know any legal right to treat a patient, certainly if they have capacity, is through the consent process. And it's like this with treatments. If we're going to offer, hopefully you didn't notice that, we've had a bit of a blip in weather and electricity, but it's all about consent, and it is a process, and the same is in regards to the Mental Capacity Act, which I know we'll talk about more with webinar 5. So if something is on the menu, then we need to talk to the patients, we need to explain the benefits, we need to explain the harms, and then it is up to them to decide if they have capacity whether to accept that treatment or not. And we have moved just recently away from what we always considered was the Bolam test, which was the standard of the clinician, to what we know as Montgomery, which is the particular patient. So we need to tell patients the facts that affect that patient. So it's once again more individualised. Like have you said, we're going to be talking more about Mental Capacity Act in webinar 5, but obviously any legal right to treat somebody in whom lacks capacity, patient lacks capacity, is about following the Mental Capacity Act and our code of practice underneath that. And it is once again a process that's defined in the Code of Practice. So as I said, medical ethics makes things difficult, not difficult, but more complex, I think, for clinicians, because medicine is relatively easy and straightforward, although I'm sure some people will argue. It's, what we can and what we can't do for certain conditions is reasonably quite clear. The issue is often very difficult and complex, is actually what should we do and what we shouldn't do for that patient. So, as a resuscitation officer, I've lived my life 18 years using flowcharts. So hence, I love flowcharts and algorithms to help. And in the joint statement, which has been updated since Tracy, there is this decision-making framework. And it is really quite clear about where the law stands and what we need to do as healthcare professionals. So I'm going to follow that framework to discuss advanced care planning and treatment escalation planning, whatever you use. So the steps are, do we need to complete a treatment escalation plan? Whose decision is it? And this is based on whether each treatment is on or off the menu. Then that will inform what type of discussion we're going to have with the patient if they have capacity, or what type of conversation we're going to be having with the family if they lack capacity. Then we're going to talk about documentation, and then the what now. And there seems to be quite a few myths around what happens once the treatment escalation plan is in place or an advanced care plan. So certainly the care providers in Cornwall, so Trelisk and Cornwall Partnerships, I'm not aware of any GP practices that have a treatment escalation plan or advanced care plan for all their patients, I'm pretty sure. But some trusts have moved to an all-patient policy, and certainly I'm aware that Plymouth has. So for patients who are admitted to Plymouth Acute Trust, they will have a ceiling of care plan, a treatment escalation plan completed within about 6 to 12 hours of admission, unless you're a child or a maternal mum. CFT, like RCH, say we need a treatment escalation plan if that patient is at risk of deterioration or cardiac arrest, or if you would answer no to the would you be surprised question. So what that second point is doing is it's trying to get staff to think earlier about having those conversations. It is much easier to have conversations with patients and their families when they're not so unwell. And often, and Warwick found, these sorts of decisions are made far, far too late, where the patient might lack capacity. So we're talking to families and relatives about expressed wishes and beliefs. And it's easier sometimes to have that conversation early on, so that sometimes more of the treatment decisions are on the menu. So it is about patient choice, and they feel they've got more involvement.
So it's relevant for patients with advanced disease living in their own home, or residents of care homes where we know they're much frailer and nearer the end of their kind of life. It's not just for kind of hospital clinicians now. Really good treatment escalation planning would start sort of in the community early on.
Absolutely, they can absolutely start wherever, and you can appreciate in the context. I think about my sort of parents who are in their 80s, going to their GP about something that they have wrong, and it feels a bit calling to then start having those conversations. But often those patients can be empowered through leaflets, through televised, through publications, lots of different ways to actually start asking some questions before. And in fact, actually, my parents started having that conversation and then started going to talk to the GP. So I went home as a caregiver and in an acute hospital, and actually then started having that conversation. So, and I know there's televised, I'll say it now just in case I forget in a minute, but there is a televised one show that's available on YouTube that you can signpost patients to, which is them actually talking about CPR decisions and putting it into context.
I think in Cardiff as well, linked in with Dying Matters, they've done a series of videos as well to help patients and professionals, so we can share those on the CSE website.
People like to get a lot of information in various formats, and certainly much more on the internet there. So that is available on one of the platforms about helping people make decisions. So we've made this decision. We haven't got an all-patient policy. We've made this decision that we need to have a discussion with this patient because we're either concerned that they might deteriorate and or suffer a cardiorespiratory arrest, or we're thinking to ourselves, I wouldn't be surprised if this patient died in the next 6 to 12 months. I'm not expecting it, but I wouldn't be surprised. And this is where the crux of the matter comes into, because to die, which is a part of living, however sad, somebody needs to suffer a cardiorespiratory arrest. And in one context, a cardiac arrest feels it's a medical emergency, and we need to make every effort to try and stop that patient from dying. But on the other hand, like I said, dying is a part of living. So we need to recognise that when we're starting to think about whether these sorts of treatments are appropriate for this patient, and also their preferred place of care where these treatments are going to be delivered. So we've made our decision about that we do need to have a ceiling of care, and it may well be that the patient themselves, as you said, takes it off the menu. So a competent patient by law can refuse treatment, and it takes the form of an advanced decision to refuse. And you will talk about that next week, what constitutes a valid and applicable ADRT. So they might actually say to you, and that's what my mum did, she went to the GP and said, I don't want to be resuscitated. And then we come from our perspective, where we're looking at this patient and we are thinking that certain treatments, including CPR, are off the menu. And this is because we think that treatment is highly unlikely to work, or there is no purpose to providing it. So in the context, everybody will know different sort of treatments as consultants, but in the context of CPR, the public expectations that CPR work is fueled by TV.
Everybody's watched Casualty, haven't they?
Yes, everybody watched Casualty, and I can't watch it because I get very upset about it all, because they, like me, think that if it's a modern day drama, they must follow the principles of what is actually in reality, and of course it's far from it. So what they see is that 80% of patients that have an arrest in a television drama or film, something like that, will survive. And reality is far, far from that. The National Cardiac Arrest Audit, which looks at data for an in-acute hospital cardiac arrest, has an average that patients will be discharged from following an in-hospital arrest, 18.4% of them.
Oh, that's quite low even for an in-hospital.
In an acute hospital, absolutely. So these are patients who arrest, they've got a crash team, drugs, lots and lots of equipment, treatment procedures, cath labs, 18.4% will be discharged. However, neurologically intact, not all of those 18.4%. And if you look at the driving rhythm of the arrest, we know the survivors are more likely to come from the shockable rhythms of arrest. And those potentially will be those sudden and unexpected cardiac events, because that's the other misconception for the public. A lot of the public think a cardiac arrest is predominantly caused by a heart attack. They don't understand that a cardiac arrest can be caused by lots of different reasons, and hypoxia and organ failure, which is what we're expecting around death, is a cause of arrest. So
it's not a treatment for natural dying.
It's not a treatment for natural dying, absolutely. So 18.4%, there is, as clinicians, it's very sort of difficult, but there is actually a piece of research which was called GoFar, which looked at neurological outcome following an attempt at resuscitation. So it was good outcomes following attempt at resuscitation. They call it GoFar paper. And that looked at studies in an acute hospital, again, in the United States, 366 hospitals in the United States. What they found was very similar. 18% would be discharged, but actually only half of those would have good neurological outcome. So only 9% would actually be discharged from hospital without the effects of a hypoxic brain injury, which is often the resulting last illness, actually, for patients receiving CPR.
So if somebody's already got brain disease, we know in dementia is brain disease.
Yes.
Then that's going to be worse.
And that will drop it. If you use that, so there's a calculator online which is based on their studies, and you can put in age and then tick in certain comorbidities. And if you actually just tick that they've got moderate or severe neurological deficit already, then their chances will drop to 9.4% from that 18. So if you look at the calculator and you put in 21-year-old, you have a 27% chance of surviving an in-acute hospital arrest, neurologically intact. So now you think about that in context of the community and who's actually going to be providing CPR for that patient. And sometimes the burden on families feeling that they've got to make an attempt at CPR. I feel actually, now that my mum has made that decision, I feel a general sort of relief that I'm never going to be put in that position, that I'm going to have to attempt and everything that goes along with that burden, knowing that it's more likely going to be unsuccessful attempt. So when we're thinking about these treatment decisions, we're thinking that's off the menu. These treatment decisions are off the menu, but these potentially are on the menu. And these are going to be things, especially relating to end-of-life care in its pure forms. The patients that are GSF Red is comfort, care, support. But for others, it might be IV fluids, IV antibiotics, it might be CPAP, it might be going to an acute hospital, but not necessarily to an intensive care department. And for some of us with the ceiling of care, it will be full CPR and all the interventions, so high escalations of care. But then it's really important that actually I decide, so the patient decides whether I want those treatments. So when we start having a conversation, if we're looking at a patient with capacity, first of all, do they want to be involved? So we can't be forcing discussions on patients, but generally patients do these days, so we can ask them. And if we are coming from the point of futility or off the menu, then our purpose of having that conversation with the patient is to inform them. It is not about asking them. And this,
I think that's often where it kind of gets mixed, doesn't it? I think as clinicians, I think we have to ask everybody, make everybody have their choice. But actually, if it's, as you say, if it's off the menu, and we know that it's not going to kind of have a good outcome,
absolutely,
we're there to kind of inform. I think.
Absolutely. And the Tracy case, which went to the Court of Appeal in 2014, was very clear. And there it wasn't about that the wrong decision was made. It was just about the fact that she had capacity. She was awake ventilated, Mrs. Tracy, following a road traffic collision. But she was already diagnosed with terminal lung cancer. And of course, the difficulty for doctors was about getting her off a ventilator. She had cervical spine injuries as well. So they realised that the potential for an arrest, trying to get her off the ventilator, was high. And they imposed this do not resuscitate decision, but they didn't discuss it with her, even though she had capacity, she was awake ventilated. So, but the courts were still quite clear. it wasn't about that the decision was wrong, and it wasn't about that doctors had to ask patients if it was coming from that point of futility. We weren't asking what their wishes were, but it was around that terminology, must consult, that I think a lot of people felt that we must ask and must abide. But CPR is a treatment like any other. You know, patients in law cannot demand treatment. The clinical teams don't feel are indicated or applicable for that patient based on burdens versus benefit. So the precedent was that you must consult with a patient that has capacity, and the purpose here will be to inform them. And this is why the treatment escalation plans are such a step in the right direction, whatever the form, and we're going to talk about that in a minute, because you are clearly saying this is what we are not going to do, but this is what we can do if you want this. So it puts CPR in context. So if, of course, a treatment is on the menu, like any other treatment, it's about consent. So we need to put the burdens, benefits on the table for that patient, and then it is absolutely up to them to decide what they want. But as it's a process, it's not just about good quality communication, it's about information giving as well. So there are various formats. Like I said, you can use technology online to look at different sort of videos. Go to, like I said, the Wales website. Devon Tepp for a while had a website. I think they're going to get the website up, which talked about patient stories, throwing treatment escalation plans a very positive light, which is what they are. In our trust, we have patient leaflets, and they are available out in the community for GPs. We have a community-facing leaflet, which talks also about preferred place of care. So where would you ideally want to be treated? So if we're talking about a patient without capacity, then of course we're following the Mental Capacity Act. And it is once again a process that, and there are 5 sort of key points you're going to cover, I know, in the next webinar. But the 5 principles are these: that we must assume the patient has capacity unless otherwise established. Can we actually withhold this treatment decision until they have capacity? Are they likely to have capacity? And can we consult with them? Everything must be done to help that person. As I said, it's about information giving in various formats, having support with their family and their friends if they require that. And just because we know an advanced decision to refuse treatment, even if it means it will end in their death, does not mean that they lack capacity. And I'm reminded of a case of Miss B, who was a 48-year-old lady on a ventilator, who told the doctors to stop ventilating her. And there was some discussion about whether she had capacity because depression following long-term recovery in an ITU, to such a point where she felt frustration, so she took them to court. And the court decided that actually she did have capacity and she could absolutely have the right to turn the ventilator off, knowing that as soon as they did so, she would not be able to breathe on her own.
That's it. And just because somebody has dementia, they don't necessarily lack capacity for these decisions.
Absolutely.
It's key to assume, not to assume.
No, and everything about treatment escalation plans, advanced care planning, is about individualised care planning. It's making decisions with the patient as well, with their family, based on what is going on with them. And I know you're going to be talking about the test for capacity. I call it HERBI, Head, Understand, Retain, Balance, Express. So I won't go into that. So. And then any other treatment decision must be done in patient's best interest. And there was just a little case, I'm just talking about, I won't say too much, in 2015, which was about calling family and the involvement of family. So here, the Mental Capacity Act is clear that if time allows, and we don't have to make an urgent decision, if time allows, we must consult with others to help to find what is the best interest of that patient. A lot of research shows that the worst person, the worst people actually deciding quality of life for somebody else is clinicians. Slightly better are their family, but the best person deciding is the patient themselves about their quality of life. So, and that's why we have this sort of discussion process. So we're having that discussion, we've had that discussion, but often, well not often, but sometimes it can be disagreement, and patients absolutely have a right to challenge us about our decision making. But bearing in mind that patients in UK law, as we stand today, can refuse treatment, but they cannot demand it. But they need to know and understand the reason why. And if we go back to what the public expectations of CPR is, and their understanding of what leads to CPR, then it's about clarifying that for them. So what we say is, if it's been a deputy up to this point, then the courts would expect that there's been some sort of consultant or high-level GP consultant level decision, a resolution. They might expect that there has been a second consultant, unless there's been a multidisciplinary team decision. And that's not necessarily a sit-down MDT case conference about somebody. It is about having award for healthcare professionals or other interested parties.
So in a community that can be challenging, but it might be getting another GP or clinician within the practice, or the community matron, or the specialist kind of nurse or consultant that's seeing that person, kind of leaving the decision until everybody's had a chance to sort of discuss it with them and review it. I think
absolutely
it can be challenging.
And we as a trust, and I know that Tariska looking at this, we've rolled the training out now to more senior nurses who have the skills, who know the patients, and can actually act as what we call a deputy. And there's always an understanding that a deputy can be a doctor, and who's not consultant or GP level. And we've always respected that. As allied healthcare professionals, we'll use that as an authoritative form. But now we're actually involving the nurses, because like I said, sometimes they're better placed to have they know the patients, they know the family well, and they can make those decisions in conjunction with their GP. So Janet Tracy case was very clear. Multidisciplinary team decision can negate a second consultant. If there's any problems, especially relating to children, we're not talking too much about children here. Often, you'll seek legal advice much quickly, and we talk about providing CPR until such case. And then we come to documentation, and very sadly, maybe it's not because it's my form, but I think we're so overburdened, or it feels like we're overburdened with paperwork. And sometimes these forms, in whatever format it is just seen as another form to complete. So it's seen in a negative light. And we've looked at, as a multi-agency working group, we looked at respect, we looked at Dementia, we took certain things from Dementia and developed the Cornwall Treatment Escalation Plan in 2015. It's under review at the moment, and we're meeting with Devon, Tapley's, George, Lily, and Mick Mercer in January to see whether we'll either move towards the combined Devon and Cornwall TAP, or we'll be moving to respect document. But I don't think the form makes a difference. I don't think there will ever be the right form. What I say to doctors and nurses using these and allied healthcare professionals is this is a communication tool. This is about helping your colleagues understand what process these discussions have gone through, what decisions have been made, who it was made with, so that they have that authority to withhold CPR. We've got into a bit of a slight nonsense, though, where patients sometimes in the community, and we've had it in Cornwall, who are clearly dying and having palliative care services coming in, but because there hasn't been a TEP with a do not resuscitate in the patient's home, staff have felt pressured into performing CPR. And we've got to work at that. I think we're going to be looking at that to say about where we're going to be talking about electronic forms in a minute, about how we can stop that from happening. But of course, as a nurse and as an allied healthcare professional, my authority comes from that form to withhold it, because the default position is that we must attempt. Whatever the form, it's about completing all the mandatory elements of it. Trying to be as clear and concise with your reasoning and the treatment decisions that have been made, including preferred place of care, who's been involved. If no involvement, why? So the Janet Tracy case said that we must consult with patients with capacity. The caveat or clause, rarely, is if you felt that that disclosure or that conversation was going to be harmful, you can withhold it. So it is vitally important here that you write why you have not discussed these decisions with somebody who has capacity, because it's a requirement under the Janet Tracy case. In the same way, if we have to proceed and make a decision because there isn't time, why we haven't been able to consult with families, it may be that we haven't got hold of them, can't get hold of them for some reason, or we're appointing an INCA. I know you'll cover that next time. It's making sure you document if there's been team involvement, making reference if there's no room where else those records can be found about a more explicit sort of more in depth, sign clearly, date, and of course about update. We're going to talk about that. So we are moving to electronic records. And considering I started in computers before I went into nursing, I'm still a little bit nervous about electronic forms, because the issue is we don't have a shared system. That's the sad fact of life. EMIS, Rio, Maxims, Intralisk, lots of different electronic systems available out there. So unless they're really all talking to each other, we're still going to have this issue of knowing that the information is there and which is the most up to date. So for us at the moment, we're looking about building a TEP on Rio, and it's about who's going to be completing that. And is it only anybody who has the same right to complete a form actually will only complete it?
Or whether that's for us within the trust, or is that going to be in the community?
So this will be us as a trust. What other GPs will be doing, because I know that they're trying to build into EMIS, I know some use System 1, and they're trying to build templates into those.
It's a challenge, isn't it? We need to get a record that everybody can access.
And we might get there with something called Coordinate My Care, which has come out of London, which is a platform that will integrate with certain electronic systems. So when you go into your system, there will be an icon so that you can actually access it, or you access it following a URL. So you go to a separate URL, which is obviously not so good. For us, it's the question about who completes it online is whether we transcribe. So therefore, if a nurse has a patient that's come with a treatment escalation plan, whether they can actually transcribe that information into that electronic format, and we're not sure yet.
No, there's challenges, but it will help as we're writing one form. If that one form written gets lost, so I think electronic records will help.
At the moment, we're still needing paper forms, certainly for transfers for SWAST. So the issue then is, if that information is there, what's it going to look like when it's printed off? Because some healthcare professionals get very reliant on looking at certain papers. And like I said, if you're in somebody's home and you're looking at a form that you're not used to, you're going to doubt, I think, and question. So it's about how we can print this off. And
we get a lot of Devon forms, don't we?
Yes.
Cornwall, but they're still valid, aren't they?
They are still valid, absolutely, they are still valid. As more and more come, especially out of respect, patients are coming back from other organisations, the usual respect form, we will get used to it, but it's just changing. And will the paper copy look like the paper form? And if not, like I said, staff have just got to get used to it. And if there's paper and there is electronic, which is valid, and you have to say, based on date, the default position would be the latest treatment escalation plan, and date would be valid. So we've had our conversation, we've documented it clearly on a form. We now need to sort of start thinking about what happens with that form. And I would just suggest that if you're changing important information on a form, so treatment decisions becoming no that were yes, or vice versa, then ideally we should complete a new form, only because we just need that clarity for staff. It's basically just got to be kept. Everybody will have different ideas about where the treatment escalation plan is kept. And in the hospital, we do the front of medical notes. In the home, there'll be certain places.
Yeah, sometimes people stick them, see patients stick them up in the room or on the fridge, but there's also the iron bottles that people can put them in there.
Yes, there's the green sort of first aid bottles, and they put them in. That's
important to let people know to keep them somewhere kind of safe, because there's nothing worse than it being lost when it's kind of needed, really.
The whole thing about these treatment escalation plans is about communication. It's good communication with the patient, but it's also about communication with our colleagues about what is going on. The other myth is that it invalidates after a certain period of time, and it doesn't. A treatment escalation plan or an advanced care plan, sealing of care plan, respect form is valid unless cancelled. The difficulty for staff is how old is old. So if they're picking up a form that's 2 or 3 years old, are they going to really believe and act on what is in the form? And I haven't mentioned before, which is actually very vitally important, is a treatment escalation plan is for clinical guidance only. And we're going to be talking about where you might overrule some decisions that's written in a treatment escalation plan, and sometimes the date might encourage that sort of questioning. So how old is old? We've tried to develop a standard operating procedure around text to say a year. So ideally a year, update it in line with the patient's review, but it doesn't have to be. It is valid unless cancelled. Review is dictated by the clinical circumstances. In the joint statement guidance, they say about changes in healthcare setting, even within an acute hospital. Any change should require a review, any change in clinical circumstances, condition, any review generated and requested by the patient themselves or the family. If it's been a patient's wishes, they might, to have CPR, they might change their mind and say they don't want it. As I said, it's for clinical guidance only, and I think the easiest scenario to mention is a DNAR where the patient says they do not want to be resuscitated. It's based on patient's wishes, but they have a choking and they go unconscious. And an unconscious choking requires staff to start compressions and ventilations. And here you would be considering that reasoning for that treatment decision. Does it apply in these circumstances? So you consider, well, actually, the patient probably didn't envisage saying that they would want choking to death, so you would maybe make an attempt. So it's for clinical judgment only.
I think for the review, so with patients living with dementia, GPs do an annual, there's an annual kind of review that's done in the community, and I think kind of reviewing whether there's treatment escalation planning or advanced care planning.
It's good to do it within that sort of month of review. I know we're running out of time here. So the other, just finally, is there's a little bit of doubt about, or a little myth around that the treatment escalation plan has to stay with the patient. And ideally it will, because there's been good communication and agreement, and patients sometimes like them and they use them as an advanced decision to refuse treatment. The difficulty comes where there has been disagreement. So if you've had a patient in hospital and a DNAR is in place, even though they were requiring it, but there's been a discussion, second consultant decision, and they get better, then you're not going to enforce that decision on them. You're not going to make them take that home. At the end of the day, we have to think about who is going to be providing that treatment, and in their home, their relatives have a right to start it and a right to call 999. It's all about communication, and as we said, we do respect, and we do respect Devon treatment escalation plans. We advise, ideally, put it on a new Cornwall tap. Just to sort of help staff, but absolutely it is valid.
I guess if you change place, then it may be that the decisions will change.
And
sometimes
it might be, yes.
The admission to acute hospital might change depending on the community hospital, whether they're at home or what treatments are.
Yes, but if a Devon TEP comes out with a patient and all of the treatments, the decisions, the clinical circumstances remain the same, we don't need a new form necessarily, but it's just about endorsing it. So updating it to putting a date and a signature on that form. And as Janet Tracy case reaffirmed, sometimes as clinicians, we need to make urgent decisions in urgent circumstances. So that does not require us to start CPR on somebody because we haven't got a treatment escalation plan completed and we haven't been able to speak to the family. Much easier to do, as I said, if you're a doctor and you have that medico-legal responsibility, which you've always had, obviously less so for a nurse and certainly some junior nurses and allied healthcare professionals to make that decision. But we have to put things in place so that, like I said, not having a TEP does not, make us have to perform CPR on somebody in whom they are dying. So we're looking at as a trust now. So lots of information available out there. The joint statement and the flowchart that I've followed is in this joint statement, and I think it is a really good tool to use if there's any doubt about how to progress with that advanced care planning with the patient.
Yeah, so I think for people living with dementia, planning ahead, having the conversations
early,
yeah, be reviewing treatments, burden versus benefit, finding out what the person's wishes are, where would they want to be, where would they want to die, remembering the principles of good palliative care that are relevant to people living with dementia, really. But I certainly think communication and having conversations early and thinking ahead is probably key, really, to dying well in dementia.
It is vital. Yeah.
Thank you very much.